This meeting is being recorded.
Good morning and welcome. This is the third presentation for health disparities under the Healthy Aging series. The Healthy Aging series is a collaboration and it is jointly sponsored by OLLI, the University of Michigan Department of Geriatrics, the Turner African American Services Council, the U of M Silver Club, the U of M Institute for Healthcare Policy and Innovation, the Turner Senior Wellness Program, and the National Poll on Healthy Aging. My name is Edna Jackson Gray. I volunteer with the Turner African American Services Council and OLLI. And it is my pleasure today to moderate this program. The program has a slight change in it today in that our original presenters have had such difficulties. Dr. Lonnie Joe has had a health emergency, and Dr. Denny is a surgeon and has been placed on call. But we are so very, very, very fortunate to have Dr. Silas Norman as our presenter today. The topic today has changed in that it is kidney transplantation, improving access and outcomes for patients. While the topic has changed, the focus of health disparities and aging remains the same. Dr. Norman is on staff at the University of Michigan, and I will introduce him in detail a bit later. But right now, we are going to concentrate on looking at our Zoom presentation software. Immediately after Dr. Norman's presentation, we will have a question and answer session. If you wish to submit a question, please click on your Q&A icon. That icon, depending on your device, will be at the extreme top or the bottom of your viewing window. Please don't put it in the chat. Click on your Q&A icon. If you experience any type of technical difficulties, such as your screen freezing up, the best solution is to exit out and then to re-enter. If you continue to experience any kind of technical difficulties, please contact the Turner office at 734-998-5393. That is 734-998-5393. It is now my pleasure to introduce in detail Dr. Silas P. Norman. Dr. Norman was born and reared in Detroit, Michigan. He received his degree in psychology from the University of Michigan, and 2 years after the following 2 years, he worked as a he worked with the Lutheran Social Services of Michigan. He then attended the University of Wayne State University School of Medicine. He graduated with honors, and he was elected into the Alpha Omega Alpha Medical School Society, the Alpha Omega Alpha Medical School Society. After completing his residency at the Baylor College of Medicine in Houston, Texas, Dr. Norman returned to the University of Michigan to pursue nephrology and transplant nephrology fellowships. Dr. Norman has been on staff at the University of Michigan since 2002, working as a nephrologist in the transplant program. He currently serves as the medical director of the Transplant Multidisciplinary Ambulatory Care Units, which serve over 18,000 patient visits annually. He also serves as the clinical chair of the Internal Medicine Promotion Committee and as a member of the University of Michigan Medical School Admissions Executive Committee. Dr. Norman's research interest is in kidney transplantation in HIV-infected patients, improving access to transplantation, and the evaluation of medical frailty in kidney transplant candidates. Dr. Norman is on numerous regarded highly organizations. He is also the vice chairman of the board for the Kidney National Foundation of Michigan, and he is an active member with the Minority Organ Tissue Transplant Education Program in Detroit. It is so very, we are so very, very much thankful for Dr. Norman joining our presentation today. Dr. Norman, the platform is yours. Thank you so much.
Thank you so much for the kind introduction, and good morning, everyone. Give me one moment to share the screen and we'll get started. I am pleased to have the opportunity to speak with you this morning and share some time talking about transplant. I also am happy to anytime to cover for Dr. Joe, and then in particular for Dr. Denny, because I know how much Dr. Denny is a supporter of the University of Michigan, particularly how much he loves the U of M football team. So this morning, I'd like to spend a bit of time talking to you about kidney transplantation and how we might improve access and outcomes for patients. And as we go through and talk about transplantation, what I'd like to do at each step along the process to getting a transplant is just point out some of the barriers that we may see for patients in terms of age, in terms of race, so that we can explore some of those barriers and what we might do to improve access for patients. No disclosures related to this presentation. And so this morning specifically, I'd like to talk to you a little bit about the epidemic of chronic kidney disease that we have in this country. I'd like to further talk to you a bit about why kidney transplantation is the best therapy for end-stage kidney disease. And then finally, spend some time talking a bit about the barriers to access, as well as some of the policies and transplant center level programs that we have to improve access and outcomes. So to start with, just to set the stage a little bit, to talk about kidney disease in the United States. And so kidney disease, the end result of which is end-stage kidney disease in the United States, you can see on the left-hand side this pie chart that breaks down the main causes of kidney disease. And you can appreciate in this chart that far and away diabetes is the leading cause of kidney disease in the United States, followed by high blood pressure. And if you look on the right-hand part of the slide, what you can appreciate is that chronic kidney disease is incredibly common in the United States, such that overall about 1 in 7 individuals, adults in the United States has chronic kidney disease. And if you think about that, there's very few diseases that you can think about that have that kind of prevalence in the population. And importantly for the work that we do, you can appreciate that the majority of people who have chronic kidney disease don't know that they have it. And this often includes people who have fairly advanced kidney disease. If we turn a little bit to those major causes of kidney disease, diabetes and high blood pressure, and how does that impact us, and what does that have to do as we think about the a particular impact in our older population? On the left-hand side, you see a bar graph that looks at the proportion of individuals in the United States who have diabetes, separated in purple men, in blue women, and then further separated by race and ethnicity. And what you can appreciate is that there's somewhere between 8 and almost 15% of different individuals in the country have diabetes. So that's as many as 1 in 6 individuals in some populations have diabetes. You can appreciate when we look at some differences that looking at ethnicities, you can see that Native Americans, African Americans, Hispanic individuals have a higher frequency of having diabetes than white non-Hispanic individuals, and so we see some disparities even in the incidence and prevalence of diabetes. And there's over 20 million people in the country with diabetes, so it's a big issue. If you look on the right-hand side of the slide, this looks at high blood pressure or hypertension. And importantly for us, if we look at the top graph here, again, a bar graph, this is looking at age. And so if we just focus on men for a moment, we see that individuals in the 18 to 39 range, individuals 40 to 59, and individuals 60 and older. And I think it's worth noting that when you look at individuals in the United States who are 60 and older, somewhere around 3 out of 4 adults are going to have high blood pressure. So it's highly prevalent. Over 70 million people in the country have high blood pressure, and the risk of this disease goes up as we get older. And insofar as diabetes and high blood pressure are the leading causes of kidney disease, we're going to expect to see more and more kidney disease in older individuals in the United States. At the bottom, you can appreciate that similar to diabetes, that although the frequency of high blood pressure in the United States is high across adults, we can see among African Americans that proportion of individuals with high blood pressure is even higher, such that more than half of all adult African Americans have high blood pressure. And why do we care about chronic kidney disease and end-stage kidney disease? Well, the main thing is that end-stage kidney disease is associated with a high risk for mortality, for premature excess mortality. What this slide shows us in black and orange are individuals in the general population, and then in blue and red, individuals who are on dialysis. And across the bottom, what we have are age categories. We can appreciate, if we just look at the black line, that of course, when we're thinking about mortality, when we're young, risk of death is low, and as we get older, the risk of dying is higher. What's important as we look at the issue of chronic kidney disease and end-stage kidney disease is you can appreciate with the blue and red lines that even in young individuals in the population, they have a substantially elevated risk of death, such that young people have risk of death that we usually associate with people in their 70s, 80s, and 90s. And so the risk of mortality is the main reason we care about kidney disease. If we think about this, we can also think about it from a financial impact that it has on the country. So we talked about the number of people with kidney disease. So some 37 million individuals in the country have kidney disease, and over 700,000 individuals have end-stage kidney disease. That is, folks who are on dialysis or have a transplant. You can see that kidney disease, in terms of mortality, 9th leading cause of death in the United States. And that doesn't even really account for all the death that's really attributable to excess heart attacks and strokes related to kidney disease. You can see that when we look at Medicare spending, you can see that the chronic kidney disease population, taking care of those patients, accounts for roughly $1 in $5 that we spend in traditional Medicare, or somewhere around $114 billion annually, just taking care of people who have chronic kidney disease. So it's extraordinarily expensive. And then when you look at people who've progressed to end-stage kidney disease, who are either on dialysis or transplant, if you look at the entire Medicare population, those folks with end-stage kidney disease only account for 1 out of every 100 beneficiaries who have Medicare, but they cost Medicare about 7% of Medicare's budget. And so people with end-stage kidney disease are very expensive. They cost Medicare about 7 times their representation. Individually, around $35 billion. And so kidney disease is not all just disastrous for individuals. It also is extraordinarily expensive for all of us. So there's a couple of options for people who develop end-stage kidney disease. They can be on dialysis, either hemodialysis which is what people often think about, where you're hooked up to a machine, usually 3 days a week for 3 or 4 hours at a time, or peritoneal dialysis, where we use the abdominal space itself as a way to clear out waste products and excess fluid. Or people can get transplanted. Kidney transplantation, so this is what I do. I do the medical component of kidney transplantation, where we try to take people who have diseased kidneys, get a healthy kidney from either a deceased donor or a living donor, place that new kidney into the abdomen so that people have good waste clearance and water management. And why do we do kidney transplant as opposed to just putting people on dialysis? Well, this is a slide that looks over the last 20 years or so and looks at risk of death. And what you can see in yellow is transplant, and you can see a relatively low risk of death in these patients. And you can compare that to individuals who are on dialysis in blue, and you can see that for the last 20 years, there's been a substantially higher risk of death in individuals who are on dialysis compared to transplant. And so we do transplant to decrease people's risk of dying. If we look at this a slightly different way, one of the things that happens when people are on dialysis is that people may initially appear to be doing quite well, but in fact, being on dialysis is associated with a pretty high risk of mortality. And you can see in blue, this is your survival if you have a transplant. In red is your expected survival if you're on dialysis. And you can appreciate whether we're talking about people transplant or dialysis at 1 year, 2 years, 5 years, 10 years, you can see at every time point, people with a transplant are more likely to survive. And in fact, you can appreciate if you look at 5 years of dialysis, you can appreciate there's a 40% survival, which is to say that for everyone who starts dialysis today, we expect only 4 out of 10 people to be alive in 5 years. And so people do substantially better with transplant, and that's why we push for it. Well, there are some challenges. One of the challenges is just the number of people who develop kidney disease in this country. So this shows the incidence or new cases every year of kidney disease. And you can see that currently represented in blue, we have about 130,000 new cases of kidney disease every year. Because people live year over year, at this point in the United States, we have somewhere around 500,000 individuals living with kidney failure, the majority of them on dialysis. And at the same time, looking at those same numbers in terms of new cases and everyone living with kidney disease, at the same time, as great as kidney transplant is, we don't perform enough kidney transplants to take care of the whole population. And so every year we only perform about 23,000 transplants. And so kidney transplant ends up being a relatively scarce resource compared to the population at need. With that in mind, like any scarce resource, then we start thinking about how we allocate that resource. And of course, with any scarce resources, then it's going to bring up issues of health disparity. How do we make sure people have equitable access, and who's at risk to not have equitable access to kidney transplant opportunities? And so let's look at that. So in Michigan, if we look at the number of people who are waiting for transplants, you can see that far and away, kidney transplants are what people are waiting for. Over 2,000 individuals in the state of Michigan right now are waiting for transplants. And because the number of transplants is inadequate to the supply, we end up with a long waiting time to transplantation, which I'll show you a little bit about. And that brings some challenges in, and it particularly brings some challenges in for our older individuals. And so, as we touched on, the primary goal of kidney transplantation is to improve survival relative to people's survival on dialysis. And as we think about that, it probably goes without saying that incremental survival, that is the survival difference between what a person would experience with a transplant compared to dialysis, depends a bit on a person's age, because we expect that someone's overall expected survival is going to decrease as people get older. And that's going to have some impact on how we think about access for older patients to transplant opportunities. We have some secondary goals for transplantation, primarily to improve the quality of life for patients compared to their quality of life on dialysis. And again, whether or not we improve someone's quality of life is going to depend a little bit on how well this patient's likely to tolerate complications related to the transplant procedure itself. So here are a couple of challenges that I see for our older patient population. So we talked about how the need exceeds the supply. And so in yellow here, you can see over the years, this is the median time that people tend to be on the transplant waiting list before they get transplanted. And you can see nationally overall, it's been pretty stable at about 4 years that people wait for a transplant. Now, you'll remember that we talked a little bit earlier that we expect over 5 years, only about 40% of people to survive 5 years. And so a 4-year waiting time for something that's hard to survive for 5 years brings its own challenge. If we look on the right-hand side of the slide, what you see based on age category is what proportion of people in yellow were on the transplant waiting list in the year 2000. And then you see the same information for people in 2020. And what you can appreciate on the right-hand side of the slide is that older patients, people 50 to 64, and particularly people over 65, there's been a real shift where that's really the increased proportion of patients we're seeing on the waiting list, such that over the last 20 years, we've actually had more than a doubling of people over 65 on the transplant waiting list. And in fact, people 65 and older is where we see the majority of the growth on the transplant waiting list. So there are several steps to transplantation. People have to develop advanced kidney disease to begin with. Many patients end up on dialysis initially. Subsequently, people need to get referred to a transplant center, and we'll talk about some of the potential barriers in there. Individuals undergo medical, surgical, psychosocial evaluation. And again, we'll talk about some of the potential barriers built in there, and in particular, how for some of our older patients, some of these barriers might be particularly acute. And then as we talked about, then there's, even once you make it all the way through this process, there's potentially a long waiting time, and that can be a challenge for all of our patients to end up still being a good medical candidate for transplant at such time as people are called for a transplant. So one of the things as we think about moving towards transplant is that for our patients, it can often be a very confusing process. The transplant process historically has been set up in a way that makes sense for transplant centers, but may not be the most patient friendly. And so that in and of itself brings up some of the concerns about barriers related to health literacy, educational level, and navigating this system. And so the first step is that people need to be referred to a transplant center. And usually that happens by people's treating kidney doctor or primary care physician. Many patients don't know that they can refer themselves. But one of the things that happens is that in being referred for a transplant, it requires that assessment by that person's physician. And one of the things that your local physician will end up assessing is trying to gauge your interest in transplant, which often can be not great for patients because it's hard to gauge someone's interest in a procedure that they probably never heard of and had no reason to think about. And so it may not be fair to put patients in a position in deciding on their interest in a process or procedure they've never heard of. People's social situation. And so we want people to be successful. We know that people are more successful if they have a good team around them. But often people's particular social situation, whether we're talking about people who are living in poverty, who may not have the most stable home situation, whether we're talking about who can serve as patient social support, this can be particularly acute in our older patients where their supporter, their spouse, very often may also have their own set of medical problems, medical issues that limit their ability to serve as the primary support. For many of our patients as they look for potential living kidney donors, which are often people's family. Members of the family may also have medical conditions that are prohibitive, and this is going to be of increasing frequency in our patients who are older, who are more likely to have medical conditions that keep them from being potential kidney donors. Transportation, again, goes back to some of these barriers that are going to be based on income. That is to say, our patients who are economically challenged may be less likely to have dependable transportation to get to and from the transplant center, and that can be a barrier. In our older patients, something that we've seen more and more, which is in a little ways funny, but it can be a real barrier, is we have a number of patients who have poor night vision. And so just the ability to be available to come to the transplant center in the middle of the night, if you get called in for an offer, if you have essentially yourself or your spouse who really can't effectively drive at night, that can be its own barrier. And then of course we look at people's medical adherence, and again, people's adherence can be driven by a lot of things, not the least of which is poverty, again, health, literacy, understanding what needs to be done, and just all the other things people are dealing with in their ability to manage care. And then when people come to their transplant evaluation, there's a lot of testing, which we'll talk about, that needs to be done, which again can be a challenge depending on people's and their supporters' physical capacities. So a couple of disparities. So in terms of getting referred for transplant, it turns out a patient can refer themselves to a transplant center, but many people don't know that. But typically it happens from people's kidney doctor or their primary care physician. And all the biases that are built into late referral, it's well documented that historically African Americans have tended to be referred for transplant evaluations later than their white counterparts. There's some data, older data, that women were less likely to be referred in a timely manner as well as men. And so there's some bias from providers that may impact people's access to transplant. And then we think of the timing of transplant, because we think in general, the sooner the better. The goal is to really transplant people before they're on dialysis. And we look when people have around 20% or less of their kidney function, they can actually be placed on the waiting list. But in order to do that effectively, it requires that your provider or the patient refers people before people get to that point so they can be evaluated. And we see differences again, in race, gender, somewhat with age in terms of when people are likely to get referred for transplantation. Again, you can appreciate that that timing is going to be particularly important if you think about a 72-year-old patient who we might see for a transplant evaluation. That time from when their kidney function is around 20 to when they might start dialysis, all of that time could be a couple of years, and that could be critical time for people to be on the waiting lists to still get transplanted. And if you're in a state like Michigan, where actually our waiting time is about 5.5 years, you know, that 72-year-old who's referred for transplant may not get transplanted until they're 77 or 78. And so, you know, every day, every year counts. And so if people are not referred in a timely manner, that has a negative impact on all of our patients, but may have a particularly negative impact on our older patients whose window for effectively getting transplanted in a way that does them some good is just narrower than our younger patients. And we try to push for transplant before dialysis because we know that folks who receive a transplant before they start dialysis have better kidney function and they live longer than individuals who've been on dialysis. And so the goal is to get people transplanted before dialysis, but that really requires that patients are aware and or their physicians know to get them in early. So there are a number of considerations that we have for transplantation. One is, can the patient understand and fulfill the requirements to be successful with transplantation? And again, this goes back a bit, although that makes sense in and of itself, but think about our patients who have poor educational attainment, our patients who didn't graduate from high school, for instance, they may not be particularly health literate. And then we need to think about how does that impact their access to a medical therapy, and should that impact their access to a medical therapy, or do we really as providers need to be doing better in overcoming those barriers? Can the patient manage the visit requirements of transplant? There's, as I'll show you, a lot of visits required early on. And again, We have patients who come from long ways to the center from where they live, and if you don't have reliable transportation and or, you or your spouse doesn't drive, that can be an impediment to getting, potentially life-saving medical therapy. And then there are some self-serving things that the Transplant Center thinks about in terms of the transplant program itself. Historically, transplant programs are judged on their outcomes. That is, they're judged on how long the kidneys we transplant last and how long our patients live. And so that, certainly makes sense as a measure of quality, but again, think about for our older patients, when we think about how long people are going to live, and we're looking at our older patients who by definition have shorter life expectancies than our younger patients and may have less tolerance for medical complications, how do we make sure that we are transplanting in an equitable manner that doesn't disadvantage people just on the basis of their age? We have some guidance in national policy. In 1984, Congress passed the National Organ Transplant Act, and that's the act that really helps guide everything we do in transplantation. And specific to that act were that as transplant professionals, we are supposed to be trying to make sure that we are looking out to increase transplantation in populations who have special needs. Although age wasn't mentioned at the time, the focus at that point was racial ethnic minorities, children, but also populations with limited access. And certainly in a place like Michigan, where people are traveling hours and hours, we clearly have patients who have limited access to high quality medical care. And then if we think of some of the rules, the Organ Procurement Transplant Network is sort of the government structure that helps manage how we distribute kidneys in this country. It has a number of rules that we need to follow and that we look at in transplant centers. Again, some that are good ideas, but we need to make sure that we don't disadvantage patients, particularly our older patients. So we need to make sure that the way we distribute organs is designed to avoid wasting organs, avoid futile transplants. And so we may think about, if you transplant that, 80-year-old person, is that a futile transplant? Are you going to extend that person's life? Might that kidney have been used in someone else? And how do we have those thoughtful conversations about some realities of life expectancy without disadvantaging people from access to a procedure? And then we always want to make sure we're using objective and measurable medical criteria. And as we think about that, and as you consider this, one of the most important things when it comes to estimations of how long someone is going to live, as you might imagine, the strongest predictor for that is how old you are, right? We know that almost by definition, people who are 50 have a shorter life expectancy than people who are 20. People who are 70 have a shorter life expectancy than people who are 50. And so how do we take that sort of medical fact, but again, not disadvantage people in their potential access to transplant? We talked a little bit about some of the patient selection criteria and how social stability and appropriate financial resources can be both sensible criteria, but also have risk to disadvantage individuals. We talked a bit about transportation, having additional support people. One of the challenges is often if you have really dedicated, committed people to you, but they work and they can't afford to not be at work to come back and forth to the hospital, once a week for a month. We have folks who may be disadvantaged through no fault of their own, but really as a circumstance of their economic circumstances. We need to make sure people's insurance is adequate and that people can afford their copays. And we often talk with the idea that over the first 2 weeks, we often want someone to be available for the first 2 weeks to stay with the patient. And again, many people, not because they're not committed, but can't do that because we just don't have the luxury of being not at work for 2 weeks. So there's a complicated set of medical assessments that we do for transplantation. It can be often difficult for people to navigate. There's a lot of terms people haven't heard before, and it's hard for people to sort of work through that process. And we often find, in particular, a number of our older patients have some challenges working through the process when we say, here's 10 tests that we need you to get in order to be ready. And so we need to think about how we support folks. So one of the most important things is, as people are evaluated for transplant, is how people present for evaluation and how that impacts their likelihood of being found to be an appropriate candidate. And one of the things I talk to people about is really thinking about that transplant evaluation when you come see the team, the way you think about a job interview, right? With the idea that when you come to this evaluation, you want to look your best, you want to be your best, so that the transplant center really that you're in your best light for us to look at and see that this person is a medically, surgically, psychosocially reasonable person to transplant. With that in mind, we think about folks who are having their transplant evaluation, but they recently got out of the hospital. They recently had surgery where they may not be moving around as well. That's going to disadvantage people. So we want to make sure that people understand when they show up, they really want to show up their best. One of the things we try to communicate to our local physicians is, before people get to the evaluation, that the local physician really talks to their patient about the importance of transplant, so that they engage their patient, that they start that conversation of thinking about transportation. How are you going to get back and forth to the transplant center? And that they start working on ways to improve medical care so that the patient is as medically adherent as possible, so that when we see the patient, we can say, okay, yes, this looks like a great patient. And then just from the patient standpoint, we want the patient to show interest in the transplant process. And we mention that not because patients aren't interested. Some patients, again, don't know about the process. But the other thing is that we're dealing with patients who often just don't feel well. Many people on dialysis don't feel well. And then you show up for what can often be a several-hour evaluation. It's hard to look engaged and interested, and that can be potentially held against patients because they appear to not be engaged in the process. And so we want to make sure that that doesn't happen. And then we talk to people about looking for potential living kidney donors, but particularly in our older patients, often their peer group often has a lot of medical disease as well. We talk about some of the challenges in addition for our patients. Again, we talked about that there's a lot of tests. Many of our patients need to lose weight, which can be very hard to do. It's particularly hard to do if you're on a kidney failure diet. It's particularly hard to do if you have functional limitations related to your long-term diabetes or your long-term high blood pressure that got people to needing a transplant. And then I can't overstate, it shouldn't be this way, but I can't overstate really the importance of having advocates for you, particularly physician advocates who can help push for people to be transplanted. One of the things we look at is, how robust does this person look? Does this look like a person we want to take to the operating room and expect that they'll do well? And we think about that robustness in thinking about something we call medical frailty, which we'll just talk about briefly. And we look at sort of measures of people's physical function, how well they move around. And this is important for people to appreciate, particularly as we think about age. And so about 30 years ago, a physician made a definition of medical frailty. And what she recognized was that this medically frail definition was essentially a lot of things that you might see with aging, with normal aging, along with some pathologic aging conditions. And so she described this frail appearance of patients to be a condition where you saw low functional reserve, that is, people kind of run out of steam quickly, people get tired easily, decreased libido, mood disturbance, accelerated risk of osteoporosis, decreased muscle strength, as well as a high susceptibility to disease. And we can appreciate, although this is not the same as age, these things are more likely as people get older. And so it may be that as we look at people, people's chronologic age is not so important to us, but their physiologic age is. And so we try to evaluate people for potential medical frailty as one of the conditions for being transplanted. It's worth noting that age and frailty are not the same thing. They're related. And you can see on the left, here's an example of an 80-year-old bodybuilder. And so, chronologically, she's old, but physiologically, she looks great. And I think, you can imagine any transplant center would be happy to do a surgical procedure in this patient. And then as we kind of work around clockwise, you can see patients using various assistive devices. And you may appreciate that as we see those patients, transplant centers may have more concerns about whether this is a reasonable patient to take to, at the end of the day, an important but elective surgical procedure. We have various ways that we try to measure people's frailty, and this is really an effort to make sure that we're trying to be as equitable and objective as possible in our measurement of people by doing things like measuring unintentional weight loss, by doing strength tests as opposed to seeing what we think about it, by asking people specific questions about the kind of type of physical activity they can do, by measuring how quickly people can walk. And so at least we can look at people objectively. And we do this frailty testing because we know when we look at the dialysis population, these are people who are not frail compared to people who have 1, 2, or 3 components of frailty. And you can see that over a 3-year period, people who were not frail tended to survive longer than people who were frail. People who were frail had an increased risk of death. And that informs our thinking about who might be a good transplant candidate. If we look at it slightly differently, this again looks at people who are frail, their risk of death on dialysis. And I think this is an important slide. And so this particular study looked at frailty going from 1 to 7, 1 being people who are very fit, 7 being people who are fairly ill. And what you can see is that as you move from being very fit to very ill, in red, you can see that the risk of death increases substantially. And perhaps more importantly, or as importantly as we think about transplant in blue, you can see that the likelihood of getting transplanted decreases substantially. As you get to being moderately frail, the likelihood that you're going to get transplanted goes down substantially. And so it's important as our patients appreciate sort of what we're looking at to decide who might be a good candidate. And then we think about how can we help people to be less frail, to be more active, to be more functional. And then we see in this slide, this looks at how likely people are to survive after transplantation based on their frailty status. And what you can see on the right-hand side here in the dark bar here, compared to the dashed in the lighter bar, is that people who were frail at the time of transplant over a 5-year period had a higher risk of death or a lower risk of survival than people who are not frail. So it seems that frailty has an impact in the dialysis population and has an impact also in the transplant population. Let's skip that. So once people complete their evaluation, they get on the waiting list, which is terrific. And it is terrific. But then remember, let's go back to the idea that nationally, there's a 4-year time to wait for transplant. In Michigan, it's 5.5 years to wait for transplant. So even once people make it to the waiting list, there can often be challenges for patients. And these challenges, again, can be particularly acute for our older patients whose window for getting transplanted may not be as wide. We again go back and highlight that for folks who are on dialysis, and these are folks who were made it to the waiting list. So arguably, these are the healthiest bunch of individuals in the dialysis population. We still see a 5-year where we lose 40 to 50% of people on the waiting list by 5 years. And so it can still be a challenge for our patients. And then finally, let's think about how we allocate kidneys. That is, how we distribute kidneys and in which order. How's the waiting list organized? How do people move to the top of the list? And what are the priorities that we have for transplantation? So when we talk about being on the waiting list, people are really on the waiting list with what we call organ procurement organizations. In Michigan, you may have heard Gift of Life Michigan is our OPO. There are 58 such organizations over the country. And so when someone's on the transplant waiting list, for instance, at University of Michigan, although they're on our list, they're really on the list with Gift of Life Michigan, with the University of Michigan attached to their name. So Gift of Life knows who to call when there's a kidney available. It's important to note that waiting times vary dramatically across the country. In some places, the waiting list is as short as 2 years, and in some places, the waiting list is somewhere around 9 years. And so this can be a big barrier for patients. And so, for instance, if you live in somewhere like New York, where the waiting list is 7 or 8 years, you live somewhere like San Francisco, where the waiting list is 9 years, you can imagine if you were a 70-year-old individual with kidney failure who's perfectly appropriate to be on the waiting list, and you get on the waiting list in San Francisco, you have 9 years to wait before transplant. And so what's the likelihood you're still going to be a candidate or have access to transplant when you're 79? And of course, no one chose to live in a place that has a particularly long waiting time. And so this is a barrier kind of built into the system. There are some efforts to try to fix that, but these are sort of barriers that access is not equal across the country. This shows you, not to get too far into detail of the Gift of Life like organizations across the country, but I just want to show you these dots represent each of the 58 OPOs, and I only show you this to you so you can see that it's not equally distributed. So, Texas has 3 different organ procurement organizations. California has 4. There's a number in New York. And then you can see places like Montana, Idaho, Wyoming, the Dakotas. There's no organization there. So everyone in these states who wants to be on a waiting list is really going to end up working through, Denver or Salt Lake City or one of these other organ procurement organizations that are serving these huge swaths of the country. And so access is very different. And that means, for different patient populations, how likely they are to get transplanted is also going to vary a bit. I'm showing you some of the main considerations of the transplant allocation system. Again, not to get too detailed about the system, but this is the national system we use to decide how we distribute kidneys. There are medical criteria, there's a waiting time criteria, and then we have some special considerations for the pediatric population, people who previously donated kidneys, how good the kidney is, and if people have antibodies that make it harder to match. I just want to point out 2 things. One, with the medical criteria, for every patient who we place on the waiting list, we calculate something called the estimated post-transplant survival. That is, how long do we think you're going to live after you get transplanted? And we prioritize for the transplant waiting list people who we think are going to have the longest survival. So we put that top 20% of people who are going to have the longest survival in a category to be prioritized for the kidneys we think are going to last the longest. There's a lot of good reasons for that, to make sure that patient and kidney survival are pretty well matched. It's a way to make sure we don't waste these life-saving organs. But you can appreciate in doing that, and the fact that age is really the biggest driver for your expected survival, that older patients are going to be somewhat disadvantaged there, because by definition, their expected post-transplant survival is going to be lower than younger patients. And so we have sort of an objective criteria that may still disadvantage to some degree some of our older patients. And then we talked about the dialysis time issue, which is that it's important how early people make it to the waiting list when their clock starts, because people have different windows of time to transplantation, and this can be particularly problematic in our older patients and in our patients who have multiple medical diseases. There is the opportunity that people can list actually more than one OPO. People can be listed in more than one place. That's within the rules, and that's great. And the goal is to improve access. You can appreciate that the ability to list in more than one place depends on the patient's ability to go to multiple places to be evaluated. What's their ability to get back and forth to different places in different states to complete evaluation? Is their insurance going to cover these multiple evaluations? One of the things that you may be familiar with from the news from several years ago is, you may recall that Steve Jobs, the previous CEO of Apple, he had a particular type of pancreatic cancer that might have been benefited by liver transplant. And you remember that Steve got his liver transplant actually in Nashville. And there was a lot of question at that, and even though he lives in San Francisco, and there was a lot of question there was, well, he's a billionaire, and so did he just sort of, buy his way into an organ? And he didn't. He just multiple listed. And he found a place that had a shorter waiting time, which all of us would do, and was appropriately listed. But you can appreciate his ability to do that in part is it helps to be a billionaire and to have your own plane to be able to pick and choose and fly across the country to get on a shorter waiting list, which many of our patients, of course, don't have. And so, so there are some barriers built into even, what's otherwise a fair system. And then also just want to mention, there's a big rural population that also can be disadvantaged because all of the transplant centers are in urban centers. And so particularly when you look at these white areas across the map, these are largely rural areas. You can see that there's a lot of rural areas where there's a lot of people who are by definition not living close to transplant centers. And in fact, on the right, you can see in Michigan, if you look at the state of Michigan, almost all of the transplant centers in Michigan are concentrated here in Southeast Michigan, with the exception of St. Mary's and the Spectrum system in Grand Rapids. And so you can appreciate that the patients we serve often are coming from 2 to 3 hours west. They're coming from 6 to 7 hours north of us. And so, and we historically have expected patients to come to us, and that's going to, negatively impact patients who don't have a lot of economic resources, who don't have a reliable transportation, don't have people who can drive them. And so there are some barriers built in there. Now, to end with, but there are some hopes. And so when we think about folks who live geographically far from the center, one of the things we and some of the other transplant centers have done is start having satellite clinics or outreach clinics. And so, for instance, at Michigan Medicine, we have 4, soon to be 5 different outreach clinics that are located in the west and the northern part of the state, so that we can bring access to patients as opposed to just expecting patients to come to us. And so that's one straightforward way to improve access. The other thing with the advent of COVID, of course, is that we made this transition to a lot of virtual care. That virtual care has allowed us, again, to reach a lot of people who we couldn't reach before, to make things more convenient, to make things more cost effective for patients. And so those are all good things. At the same time as we've expanded this virtual care, it's also highlighted how many of our patients don't have access to broadband. How many of our patients don't have iPads and laptops and computers to access the internet. And so we've also exposed, yet another disparity or another need. One of the encouraging things is the Advancing American Kidney Health Initiative. So this is an initiative that was signed into effect in 2019, signed into effect by the White House. It's an effort by the Department of Health and Human Services. And this initiative has 3 main areas of focus. One was prevention, to reduce the risk of kidney failure overall, to bring that demand down. The second thing was to improve access and the quality of patient-centered, person-centered treatment outcomes. And then importantly for our conversation, a specific goal to try to increase access to kidney transplants across the country. And so this is an example of a policy initiative that may help remove some of these barriers and improve things for patients. And one of the things that the Advancing American Kidney Health Initiative wants to do, besides dramatically reducing the number of people who have kidney disease, is to ramp up home options for dialysis, and importantly, doubling the number of kidneys that are available for transplant over the next 8 years, which is a huge undertaking. But you can appreciate that gap between 23,000 transplants that we're doing, 130,000 new patients in need every year, that doubling, to somewhere around 45,000 transplants a year, although it doesn't close the gap, is incredibly important and a great policy initiative that may remove some barriers to access. So in conclusion, So kidney disease is associated with a high risk of mortality for individuals. And most of that mortality is cardiovascular risk, that is heart attacks and strokes. We know that kidney transplantation is the best therapy for end-stage kidney disease because it's associated with better quality of life and better patient survival. There are a number of steps to receive a kidney transplant, and as a result, a number of potential barriers for patients. At the same time, encouragingly, there are a number of efforts at the national policy level as well as at the transplant center level to help try to improve equity and access. Thank you. Thank you for your attention, and let me stop sharing the screen, and then I will turn it back over to our moderator, and then happy to take any questions you may have.
Thank you so much for that wonderful presentation. And as an older adult, I have mixed emotions, but you've answered a lot of questions there. And we're opening it up for questions from the audience. Please remember to put your questions in your question and answer icon. So we have one here. I am a post-double. Okay, let me get back to this. My screen changed on me. I am a post-double lung transplant with kidney disease due to immune suppression. Is there increased risk of being declined for kidney transplant because of lung transplant and increased risk of rejection?
Thank you. Good question. So it is not at all unusual for folks who either had a lung transplant, liver transplant, or heart transplant at some point later in life to develop kidney disease and potentially need a kidney transplant. Having a lung transplant would not decrease your chances of getting a kidney transplant. Many of the medications for kidney transplant would be the same as what you're taking for lung transplant. And in fact, the main thing we would be looking at for you would be that functional status, that frailty measurements. We would want to know the same things we want to know for any other patient. How physically robust are you? How well did you do with your lung transplant? Did you have a lot of infections, a lot of complications, or did you do overall well? And certainly evaluating folks, like I said, for these transplants is not at all unusual. And you would not be expected to have an increased risk of lung, I assume you're talking about lung transplant rejection, because in fact, the medicines you'd be on and some of the levels you would require would be very similar to actually what you need for the lung transplant.
Thank you. Are there organizations that try to help transplant candidates with transportation? Are there funds for candidates and families to access while they're in the waiting process? Say, for instance, if they need help with transportation, motel stays, meals, that kind of thing.
Yeah, so good question. So not as many as we need and not organized in any sort of national way. So break it up into a couple of parts. So for people who are potential living kidney donors, there is something called the National Living Donor Assistance Center, and that center is specifically designed to remove financial barriers to people being able to donate at least. And so, and there is opportunities to get lost wages covered, housing, transportation, lodging. But that's for donors. For people who need transplants, of course, for some of our patients can rely on Medicaid transportation. One of the challenges to providing lodging, to providing reimbursement for gas, help with transportation, is in fact that the way it's looked at from a regulatory standpoint often is about undue incentives. And so, for instance, at Michigan, we used to have a lot of gas cards that we would provide to our patients to try to help with transportation, offset the cost. And so you can appreciate that that can be looked at as an undue inducement, that we are, coaxing patients to come to the University of Michigan because we are covering these costs. And I think, you probably have some idea about how I feel about that. but it's made it very difficult for us to provide these opportunities. We are in the process of trying to look at some third-party options, but you can appreciate, organizations still need to avoid that appearance that we are creating inducements for patients. There are opportunities to help patients. There's an organization called the American Kidney Fund, which, as a qualifier, I'm on the board of the American Kidney Fund. So one of the things the American Kidney Fund does, many of our patients who have insurance but have difficulty affording their copays, one of the things the American Kidney Fund actually does is to help pay the copays, pay the gap in the copays so that people can actually afford their insurance. That doesn't go directly to the question you asked, but if patients now have their insurance copays paid for, then perhaps they have more income that might be available for transportation and lodging when they're not spending it on copays. So, but it's a big problem. It's one of the reasons why we and Henry Ford and other transplant centers are really trying to have these satellite clinics so that we can get closer to patients. So that we can, and that we are trying to also leverage virtual care so we can at least limit the number of times patients have to come down and see us to try to minimize the cost.
Thank you so much. Another question, can 3D printing have an impact on kidney transplant availability?
So we are hopeful for a number of potential future solutions. So it turns out the kidney is a very complicated organ. Even simplifying it, it probably has 3 different functional parts of it. And so one of the challenges for things like stem cell or 3D printing has been, it really requires creation of sort of 3 different components getting them all worked well together. One of the, there are promising preclinical advancements in stem cell technology related to trying to grow kidneys. There's also some very exciting work being done on the artificial kidney, sort of an implantable mechanical kidney. There's been great work going on for more than 20 years now, which is really now getting close to something that's functional, and that really could be a game changer if we have a mechanical artificial kidney that may really take a lot of the impact off the demand for transplant.
Thank you so very much. The next question, why is it that so many people are unaware of their kidney disease?
So yeah, no, so that's a terrific question. And so again, a 2-parter. So the biggest thing is that kidney disease, like diabetes, like high blood pressure, often don't have any symptoms until there's complications. And so these are really silent diseases, and it makes it a big challenge. People may have diabetes for years, and it may be discovered either incidentally because they happen to have a physical for some reason, or sometimes it's not discovered till they have a complication of their diabetes. Similar with high blood pressure, people may have high blood pressure for years, not be aware, and it's discovered when they have their stroke. And then similarly with chronic kidney disease, even people who have diabetes and high blood pressure often don't appreciate the association of diabetes and high blood pressure with kidney disease. And we see patients who have chronic kidney disease where it's often discovered because people have complications. What brings them to the emergency room is that they started having a lot of swelling. What brought them to the emergency room is that they just felt, completely washed out and tired. And we discover in the emergency room that they have advanced or sometimes end-stage kidney disease. And so that's been the challenge. And then, of course, for our patients who don't have access to healthcare routinely, so many of us will be discovered because at least we have insurance. We'll be seeing our doctors annually. It gets discovered, but if you don't have access to care, or like some physicians, we have access to care, but we don't go to the doctor regularly, it's not going to be discovered. And so a lot of it is preventable early on. But one of the big efforts, we look at there, we have a term, it's called crashing onto dialysis. So it's frequent enough that essentially people show up into the emergency room and, before they leave, we've got them on dialysis. And so it's a silent disease. And because it's silent, even people who know they have it often think because it's not making them feel bad, that perhaps that it doesn't have any consequence, which is also turns out to not be true.
Thank you. This next question sort of piggybacks on that. What can you do to keep your kidneys healthy?
Absolutely. So so that's a terrific question, because as much as I do transplant and we're passionate about that, we're more passionate about trying to prevent disease if at all possible. And so diabetes and high blood pressure make up about 65% of all the causes of kidney disease in the US. Those diseases are largely preventable, and they are driven by obesity, by excess body weight, increases the risk for both diabetes and high blood pressure. And these are diseases you can prevent or modify with healthy lifestyle and activity and physical activity. So if people are eating well, which is, moderate portions of protein, good amount of fruit and vegetables every day, that's going to decrease the chances people develop disease in the first place. If people are regularly physically active, the CDC recommends 150 minutes of aerobic activity, walking, running, biking, swimming, for people every week. That can be challenging to do when people are working. The healthy diet can be challenging for people who are on fixed incomes. It can be particularly challenging in people who live in what we call food deserts. And so we often in this area highlight Detroit. Until a few years ago, there were no major chain grocery stores in the entire city of Detroit. And so as we talk to people about healthy eating, there's a structural problem where there's not access to high quality food. As much as we don't like pills, we all like pills, right? And we want a pill to fix stuff. And so, certainly there's a component when we talk to patients about what can I do about this? And we say, well, we need to eat more healthy and we need to exercise more, right? There's a cohort of patients who say, okay, but like we have a pill for this, right? Like what else can we do? Because, but it's largely preventable. And even once people have kidney disease, healthy diet and activity slows down the progression of kidney disease. And if people progress where they need a transplant, again, as a broken record, if people maintain a healthy body weight, healthy diet, good activity, that's going to improve, how well they do after transplant.
Okay, thank you very much. There's a question here with what has been the impact of COVID on kidney transplants?
Yes, thank you. So in early 2020, when the pandemic really got up and rolling, a couple things happened. There were a number of transplant centers around the country that essentially ceased operation for 1 to 3 months because the incidence of COVID was so high. It just didn't seem prudent to take people to surgery and then put them on immune system suppressing medications in the middle of a pandemic. And so the immediate impact to that was that our patients weren't getting transplanted and therefore at risk of dying from their dialysis related complications. Since that time, transplant centers have reopened. A lot of transition to virtual care. Our volumes are actually back to normal. And I think the biggest two things that have happened for our patients are, one, for our patients who are post-transplant, like a lot of the rest of the country, our patients have been in the house. Our patients are acutely aware of their infection risk. Early on in the pandemic, up to one in four transplant patients who got infected with COVID would die. And so we had an extraordinarily high death risk, which is improved now. And so our patients were, and if you think about it, and you think about the risk factors for COVID, obesity, chronic kidney disease, diabetes, older age, those are our patients. And so our patients would come to us often with multiple risk factors to do poorly with COVID. More recently, what we've done, certainly at our center and at multiple centers across the country, is we initially encouraged all of our patients to be vaccinated for COVID, which has been shown to be protective even in our patient population. And then we actually took the next step a few months back, and starting as of this month, we've actually mandated COVID vaccines for all of our patients who are on the transplant waiting list for all the organs, in order to minimize the chances that our patients get sick afterward.
That's something for all of us, regardless, but thank you. A next question. If you have plans to donate your body to a medical school, basically, I think they're asking, what is the process?
Yes, so there are, at least at University of Michigan, there's a website which I don't have right now, but we could find where people could elect to donate after death. And it's important for people to know, but we can certainly get that information for you. It's important for people to know, and of course, as a transplant person, I would encourage everybody to sign up to register as an organ donor. You can do that through the Secretary of State. Many people do it when they're renewing their license or other documents. You can go directly to the Secretary of State's website. You can go to the Gift of Life Michigan website. You can go to the MOTEP, the Multicultural Organ Tissue Transplant Education Program website, and register as an organ donor. I encourage everyone to do that. We looked at the demand and we saw the supply, and so we say something like, don't take your organs to heaven. Heaven knows we need them here. And so I encourage everybody to register as an organ donor. And then to the question about donating your body to science, you can be an organ donor, successfully donate your organs, and subsequently have your body donated, say, to a medical school. So those are not independent decisions. But I think if there's one thing we could encourage everybody to do is to make sure you're registered as an organ donor.
As a piggyback to that, is there an age limit for organ donations?
There is not. There is not. I say two ways. For deceased donor organs, usually if people are over 80, they're not considered for deceased donation. It's worth noting for living donation in particular. So, but otherwise, no. For living donation, the one thing that's important, kidney specific wise, is there's no age limit to donate. One of the things we see is that all of us lose kidney function as we get older as a function of normal aging. And so there are people who have perfectly normal kidney function for being 70. That's not the same as the function they had when they were 20. Many of those patients are still maybe good organ donors. They may still have enough kidney function that the kidney they donate has enough function to take care of their intended recipient and leaves them with enough kidney function. In fact, we just last week transplanted a pair of brothers who were both 71, 72. One brother donated to the other brother. So no age limit, and we encourage anybody who's interested in being a potential living kidney donor for someone to call U of M or call one of the transplant centers to start that process. And we would look and make sure kidney function and general health was appropriate, but the age itself is not a barrier.
Thank you very much. Are there similar assessment requirements for living kidney donors? And are there also discrepancies in donor evaluations?
So what we see, thank you. So what we see with living donations, so yes, there's a parallel process for evaluation. So when people want to, I'll describe what we do at Michigan, which is similar to what other programs do. When people want to be considered as living kidney donors, as you might imagine, the main thing we want to do is make sure that we don't increase our living donors' risk of developing kidney disease over the course of their lifetime. And the way we do that is by doing a thorough medical, surgical, and psychosocial evaluation to make sure that medically they're healthy, including but not limited to having normal and excess kidney function, so that the kidney they donate is a nice, healthy, normal kidney they keeps a nice, healthy, normal kidney. We make sure that they're surgically appropriate to have this procedure, and we make sure psychosocially, which is to say to make sure that, they've thought about this well, they don't have any reservations, they're not getting pushed into it by their friends or family, that they've thought through work implications, these kind of things. And if all that works out, then they can move forward as a living kidney donor. And we talked about some of the financial assistance. Some of the disparities we see in terms of living donation actually kind of go back to the disease state. So the main disparities we see in living kidney donation are by ethnicity. And what we see is that proportionally there are less African-American living donors. This is not, doesn't appear to be due to willingness for donation. There seems to be plenty of willingness, but insofar as diabetes affects all populations, but there's excess diabetes in the African-American community. Insofar as high blood pressure affects a lot of people, but there's excess hypertension in the African-American community. Those are two of the reasons people wouldn't be able to be living kidney donors. And so we see an excess of medical disease in African Americans, for instance, that limits their ability to be living kidney donors. So that's one of the challenges that we see in living donation.
Thank you so much. How does one go about getting a medical advocate or a medical coach?
Sure. So that's a great question. So there are a number of different ways to do that. So there are some places like the National Kidney Foundation of Michigan has what we call a peer mentor program. The NKFMs, and again, I should qualify everything, right? I happen to be on the board of the National Kidney Foundation of Michigan, so I don't make it sound, I'm just steering people to all the things that I'm on the board of. But the NKFM has had for years a peer mentor program that is, as it sounds like, these are individuals who have kidney disease, various states, some chronic kidney disease, some on dialysis, some who've been transplanted, who can help walk individuals sort of through that part of the process. Our program has, on the transplant side, has a peer mentor program as well, specifically designed to help patients navigate that particularly the pre-transplant side of the process. There are additional programs, some national programs that are done locally. There's a program Amy Waterman started called Explore Transplant, which is directed towards dialysis staff and patients to help them learn about transplant, learn about asking for living donors, moving through the process. And those resources are available to help connect people with at almost every transplant center. There are programs like we have one called the Big Ask, Big Give, which is a program designed to help people think about how to ask for and design materials to help get potential living kidney donors. And so there's a lot out there, a lot of resources out there to try to help people move through the process and also to help get living donors.
Is there any one place that one could go for all of those agencies?
Yeah, so it's unfortunately, a little spread out. But what I would say is, although each place doesn't have all the information, there's a lot of information on University of Michigan's transplant webpage that may be helpful. There's a lot of great patient-directed information on the National Kidney Foundation of Michigan's website. There's a lot of great patient-focused information on the American Kidney Fund website as well. And so each place won't have all the resources, but I think if you look at those pages, there's a lot of overlap and then a lot of, I think, very helpful patient resources.
Okay, do we have other questions? We have a great comment here. It says, "Thank you so much, Dr. Norman, for this wonderful talk. We were very fortunate that you were able to join us."
Thank you so much.
And I echo that. We're most grateful that you were able to come in and help us with the program. And we'd like to thank you, and we'd like to thank the audience as well for joining us today. And do we have your permission to maybe write you for some answers and comments at some point in time?
Absolutely. I'd be happy to answer or try to direct people to resources. So absolutely. And then I noticed there was a comment in the chat to highlight that in Transplant, we have a fantastic group of social workers who are fantastic resources to connect patients with a lot of support and other information.
Thank you so very, very much for this. The information is just great information, and I'm sure that we will go to the resources that you have given to us. This concludes our program for today. Again, we want to thank you, Dr. Norman, and we also want to thank our audience. Our next health disparities presentation will be next Friday, and we hope and trust that the audience will join us as well for that. Thank you very much. And I see I have a chat here. It says, yes, good talk, informative and thorough. I mean, you cannot get enough accolades for this presentation. Thank you so very much. And we will end our program as of now. Thank all of you, and have a very good weekend, everybody. Keep warm, keep safe. Thank you.